So welcome back to Taking Charge of My Cancer, episode 42. I have a really brave, grounding physician today, an excellent surgeon that I crossed paths back maybe 2016 or something, the first time I met you. And this is Dr. Wei Chen. He is a distinguished professor at Cleveland Clinic, renowned for his expertise in reconstructive microsurgery and super microsurgery. He has pioneered innovative techniques such as the octopus LVA, the freestyle acrobatic LVA, vascularized lymph vessel transplant, advanced LVA techniques for severe lymphedema, and the flying squirrel, MITESE, I don't know if I'm pronouncing this correct, MITESE, lymph-enhancing liposuction. More recently, with the discovery of Alzheimer's and Parkinson's disease being lymphedema of the brain, Dr. Chen has expanded his investigative focus to include these previously deemed intractable conditions, providing hopes to a patient population currently with limited options. As I thought after lecture, Dr. Chen has delivered over 240 invited lectures, keynote presentations, and visiting professiorships on a global scale. His expertise and contribution had establishing him as a luminary and a trailblazer in the field, committed to advance the science and practice of lymphology. So, Dr. Chen, it's an honor for you to be here with me today.
Thank you. Thank you. Great to be here.
Great. So again, we're going back. One thing that impressed me a lot about you, I've been coming across really great surgeons, but sometimes you're actually going to meet the surgeon who, oh, I am the surgeon and everybody is over here. Or I am the surgeon who loves to kind of like share your knowledge with people. And we were, I don't know if you remember that, but we were like, I believe, an NLN in Dallas back in 2016 with one of my colleagues. And we were on the elevator. And you came in and like, oh, you guys are going up. And like, oh, I'm Dr. Chen, and I'm going to give this presentation. And you actually open your laptop and start to talk to us about your presentation. And we were like, wow, like who does that, right? Like that's how passionate you are about your work. And then I remember, I believe that was like maybe the 2 years later in Orlando, we were doing a research poster presentation, and you stopped by and you start asking questions about our posters. And then you started sharing as well a lot of your work again, without even asking anything. And then that has been like super great. Like, you're passionate about what you do. Is incredible. So I really appreciate you doing all the things you do to really elevate the health for a lot of patients out there who has lymphedema and for years, no hope, right? Like this is a condition I have to live for the rest of my life, and it is no hope for it. So I really, really appreciate all your knowledge and really driven to do different things and be kind of like out of like what everybody else does. So it's great. So thank you again.
Well, thank you for the kind words.
All right, so you want to tell us about your mission and your business?
Okay. Well, my mission, that made it sound so serious. I think, as you mentioned, I think it's important. Yes, I am passionate about what I do, and as we always said, find what you love and you won't work another day. I think I'm fortunate that I have found my passion, which is to, well, initially, I think like most young men, we only had a vague idea of what we wanted out of life. And so we were looking around, soul searching a bit, and we probably had a vague inclination thinking that this may be what we wanted. So but gradually, this vague idea solidified, and it became clearer and clearer. And for me, it became clear that I wanted to become a surgeon. And once I became a surgeon, it's really a stepwise, gradual soul searching, finding out about myself. I found out that I gravitated towards precision-oriented surgery. And in the surgical world, it would be plastic surgery. And in plastic surgery, what's the most precision oriented? Well, it's microsurgery. And in microsurgery, what's the most precision oriented? What's the apex precision oriented specialty? Super microsurgery. And what does super microsurgery treat? Lymphedema. And that's how I got to where I am at. I wouldn't call that my mission. I would say it's just pursuit of my passion. And I think you mentioned how I volunteer information related to my work without you asking. And I think that's probably something that we ought to caution ourselves that just because to us what we do is incredibly interesting, we can't stop thinking about it, we can't stop talking about it, but others may not share our interest. And so yeah, that's something I need to remind myself of.
That's excellent. So before, back then when you decided to do plastic surgery, were you, I know you kind of like mentioned that you end up doing lymphedema just because when microsurgery bring you into that. Were you thinking as a plastic surgeon doing something differently, like, breast reconstruction or any kind of head and neck or?
So, well, I was trained the old-fashioned way, and I'm saying old-fashioned ways because more and more plastic surgeons are trained without having gone through a complete general surgery training. I was boarded in general surgery, which, well, I got into general surgery because as I said, I was, as a medical student, I didn't really had tremendous insight to what I wanted to do, unlike many others who knew already they wanted to be a neurosurgeon or a heart surgeon or whatever kind of specialist. I didn't know. I just found out that I had a surgical personality. I like things black and white. And so to me, treating a disease surgically is if you make the analogy of treating disease, helping a patient with a disease as well, now considering the geopolitics right now, two countries in conflict, I think non-surgical treatment would be analogous to diplomatic negotiation. So you try to go with less extreme, less invasive, less drastic measures. But when talks fail, then it's time for war. And to me, that's what surgeons do. We would have a showdown with the disease, and it's either we succeed or we fail.
Mhm.
And so I figured out that much that I have a surgical personality. Surgery is much more suitable for me. But then it's, as I said, it's a gradual finding out about oneself that I was fortunate that I identified plastic surgery and subsequently microsurgery and super microsurgery.
Excellent. Would you give us 3 value tips that you learned about your journey?
I'm sorry, what's the question again?
3 valuable tips that you learn about your journey.
3 tips.
I
So
know
I
many.
don't think that I don't see myself as a life coach. I do coach and advise a lot of medical students, surgeons, trainees and advanced trainees and surgeons in practice alike. Um, what I can share, well, as I said, I think it's important for all of us to find what we enjoy doing, what we feel passionate about. And I think that for what I do, if I see what I do as a job, if I go to work, well, uh, I don't work 9 to 5. But for whatever hours I work, if I only treat it as a work, I would be then, like most people, dreading Monday and having Monday blues. And on Monday, I feel depressed. I start to look forward to Friday. I start to count the days. And then as Friday approaches, I become happier and happier. And Friday, yay, I think if that's the mentality, we're not going to do good work. So I think find your passion. That's what I would say to all of our budding surgeons. And uh, again, I'm a surgeon. I think and breathe and live a surgical lifestyle. So I think the number two suggestion that I have for surgeons, and I think you take it for what it's worth, maybe you can translate it and apply to your everyday life, and that is to not believe in dogma. Don't believe in medical dogma, which means that, so dogma implies that there is a treatment that is the best. There isn't, because medical treatment is meant to get better with time. So you can say, what is the best treatment as of today? But rest assured that what's the best today will not be the best tomorrow and will become obsolete tomorrow. And it better be obsolete tomorrow. So I always tell my residents and fellows, what we're training you today is to the best of our ability, this current state of the art. They're cutting edge. They're the best as of today. Well, hopefully. However, 10 years from now, when you're in practice, well, once you are 10 years into your practice, you better not still doing what I'm teaching you today. If that were the case, then you fail and I fail as a surgical educator. So that's number two. There's no such a thing as dogma. Dogma are meant to be broken. So no such a thing as standards of care. Standards of care, you need to qualify by saying standards of care as of 2023. Then yes, there is a standard of care. If I were to think of a third value, I would say, or third advice to myself and also to my fellow surgeons would be, don't give up. Because what we do, the nature of what we do is so serious. Usually what's standing between us and failure, surgical failure, and a bad outcome for the patient is whether we can hang in there and not give up. So I think when we give up, there's no other choice. We just have to. Otherwise, don't give up.
That's,
Yeah, that's what I can think of.
how about if you want to give some tips to your patients? Like if you go back into your patients who are being going through lymphedema, either because oncological reasons or primary lymphedema, what would be 3 tips that will pop up on your mind?
Tips. I can come up with easily 20 tips. Um, Going along with, I think probably fundamentally, number one, going along with what I have just said, don't believe in dogma. So you've been told a lot about how, number one, I'm sure you've all been told that lymphedema, including some of the experts out there, lymphedema is untreatable, incurable. So this is where what this interview is supposed to be informal and not really about scientific hardcore science, but I can tell you lymphedema is not only treatable, it's very treatable. I think in comparison to many other medical conditions, they are much more treatable than many of the conditions that I can think of. And yes, it is curable. It is curable. I am observing lymphedema cure consistently, routinely in my practice, because of how much volume, how much patients we are treating. That said, we are curing a small percentage of patients. Vast majority of the patients that we treat, we don't achieve cure. But that doesn't change the fact that lymphedema cure as of today is already a clinical reality. So what is incumbent on us what our duty and responsibility is, we need to investigate this phenomenon. How come we are curing some and we're curing few, and how come the rest of the patients are not cured? I think the first step of finding out why is to recognize that it does exist. If people keep on covering their eyes, keep on saying, no, it's impossible. Yes, it was impossible in 20th century. We're no longer in 20th century. Lots of things were impossible and they are now possible today. So that's the first message that I have for lymphedema patients. Lymphedema is a lot more treatable than you think, and lymphedema is also curable. It is important to be properly diagnosed early. So it's not just yes or no whether you have or don't have lymphedema. What is the severity? What is the extent of involvement? How impairs your lymphatic system? There's a lot more to be learned about your lymphedema condition. Anyway, the first message is lymphedema is treatable and curable. Number two, again, going along with what I have just said, know what you're dealing with. It's not just whether you have or you don't have lymphedema. Is it involving just your left leg? Even if your left leg is the only part of the body that's swollen. You just mentioned whether it's primary or secondary. Primary or secondary does have implication. Let's take primary, for example. It's not just primary lymphedema. A patient with primary lymphedema is under development of someone's lymphatic system. So the person may have a 10% deficit, so the lymphatic system is 90% developed. That patient obviously will behave very differently than someone who has an 80% deficit and is only 20% developed. Someone who only has a 10% deficit may not even have symptoms. And if that patient develops symptoms, that patient can be very well managed without surgery. Whereas someone with 80% deficit, only 20% function, we probably should forego non-surgical treatment altogether because there are just too little lymphatic function for lymphedema therapists to work with. So number two is to find out what you are dealing with. Lymphedema, we do know I should say we do know a thing or two about lymphedema. I think we are already sharing, trying to publish as much of our findings as possible, but still lots of our discoveries have not been peer-reviewed, and we cannot responsibly share them. We cannot responsibly share them until they're properly peer-reviewed. But what I can tell you is what we do know and we haven't shared, they're mostly favorable. They're mostly good things. So you do want to find out what you are dealing with. It's not just whether you have lymphedema or not. And number three, I think as a patient, so there are different opinions in the field. What I can tell you is right now surgeons agree to disagree. At least what I can say is I'm not aware of any surgeon who isn't trying his or her best to help their patients. We're all trying to do what we consider the best for our patient. And I can tell you lymphedema surgeons are some of the best reconstructive surgeons. And this is the case around the world because lymphedema surgery definitely is, in my opinion, some of the most challenging, technically challenging surgery known to mankind. So, and nearly all lymphedema surgeons are plastic surgeons. And plastic surgeons, as you all know, can easily live an easy life doing cosmetic surgery, making substantially more money the moment we don't do lymphedema surgery and pick up cosmetic surgery. And we choose to do lymphedema surgery because many of us don't find cosmetic surgery rewarding of course, cosmetic surgery is financially rewarding, but I think the meaning of life is the pursuit of happiness, and we all find happiness in different ways.
Yeah, yeah, that's very well said, Dr. Chen. How about your most painful lesson during your journey?
Painful lesson. I think I have a good attitude. Of course, I think life is fraught with challenges and difficulties and ups and downs, but I wouldn't say painful. I think without the downs, you're not going to feel the euphoria, the happiness associated with the ups. So the ups are ups only because there are downs. So I wouldn't say they are painful. Of course, I think as a surgeon, I think what always drives us forward, in addition, so we all want to be incentivized positively. For example, you want your kid, I want my kids to score 100 in school, and I would prefer that they are incentivized by that desire to get 100 instead of being incentivized by the fear of not getting that 100 and coming home and get spanked. Uh, I don't know whether you've heard of the Asian scoring scale. A is average, B is below average, and C is don't come home.
Oh, wow. I did not know that. I know, now I can see why a lot of my...
Anyway, so as a surgeon, in addition to, we all want the best results for our patient, but for surgeon, we are also driven. There's that intense fear of failing our patients. So, but as a surgeon, complication is inevitable. If you do enough surgery, you will run into complication. You will run into results that are not the way you want it. And I think sometimes we almost wish that this is not on our patient. If a bad outcome of our own doing is on us, you almost wouldn't feel as bad. But when it happened on our patient, yes, that could be quite unbearable. But if you leave a bad result in a patient at that, and you are intimidated as a surgeon. So I unfortunately see this every now and then in younger surgeons or surgeons trying to pick up lymphedema surgery. They're trying to help. They meant well. They run into problem. They run into some unfavorable results. They then were taken aback and they stopped. That would be an example of what we shouldn't do. We should think long and hard. Is this what we should be taking on? And if we decided that, yes, this is what we're going to take on, don't give up, because now that patient pay a price. That unfavorable result, that patient pay a price for you, the surgeon, to learn a lesson. And if you learn that lesson, so many more patients will benefit. So yes, now that I think about it, yes, those unfavorable results were tremendously painful, but we learn from those results, and those patients pay a price to the maturations of surgeons. And but I can say for all experienced surgeons, I mean, all experienced surgeons were once inexperienced, and our maturations, we owe to our patients, our first few hundred patients who pay a price. And that resulted in our expertise today. And so we better use our expertise to help a lot more.
Okay. And how about for patients? What would you think will be a really painful lessons, from the patient standpoint, for like the thousands of patients that you have seen suffering with lymphedema?
I think really the most painful would be uh and this I unfortunately still seeing in my clinic is when they had come to us, they realized had they come to us earlier, we could have been doing more and surgery would have been less invasive surgery. Surgery would have been even more effective and we could have aborted the disease process. We could have spared them of years of suffering. And I mean, that's obviously a heartbreaking situation. And patients, when they found out that treatments have always been available, it's just that they're not widely available, they're not easily accessible. But they finally found out that this whole time they were not aware. So I think, well, that's the reason of doing this podcast right now, and that's why, Durley, you're doing this, is to help with patient education and
Yep.
help raise awareness. So none of us want regret. We want to have choices. On day one, ideally, when a patient acquires lymphedema, on day one, ideally, that patient is informed you have treatment options. You can choose to go with surgery. You can choose to go without surgery with lymphedema therapy. And usually, as the disease, and if your disease remains well controlled at an early phase without surgery, then you always can choose to go without surgery. And you can also choose to go with surgery at any point. But if you do decide that you want surgical treatment in general, the earlier the better.
Yep, that's an excellent point, Dr. Chen, and you're absolutely right. Um, I amaze me how I was an orthopedic therapist for a long time, and I've been doing oncology for the last 14, 15 years, and then really seeing multiple, not going to multiple symposiums and things that I just have the pleasure to meet a lot of the more amazing plastic surgeons in the world that are doing this work. And it is just, I think the common denominator is that, right? The passion for it. I know that all of you doing this for the patient, not like you say, it's not the cosmetic plastic surgery, right? So it's different. But at the same time, it's just really nice to be able to talk to a patient. And we have a prospective lymphedema surveillance program for after breast cancer, and it's just really identify it so early on that we can reverse it, and when we can start to be able to talk to patients about these surgical options, right, that we didn't have this like 12, 15 years ago, at least not the way that we talk about it now. So that's really important for patients to know that. And then I feel the same, when patients come to us and it's like, wow, I did not realize that was options for me. Where can I go? And then for years they've been dealing with, compression and cellulitis and multiple hospitalizations and those. So it's really nice for us to be able to share that info with them. Is there anything that you have that will be of value for our audience?
That's such an open-ended, abstract question. Anything that I have that would be of value to the audience. Hmm. Um, would you like me to share something that's medically related or non-medically related?
Medical related.
Medically related. Okay.
So how about like if I know that so for our audience, so Dr. Chen used to do lymph node transplants, right? You don't do those as much anymore. So maybe you can explain to our audience a little bit of a difference of like what
Okay.
is lymph node
Yeah.
transplant.
That part is easy. And actually so recently I was asked to, so I usually get asked a lot to give all kinds of lectures. And one of the most common lectures, people would like me to give an overview lectures because I think there are a few surgeons, nowadays, fortunately, there are a lot more lymphedema surgeons worldwide than what we used to have 15 years ago. But still, fairly few surgeons do the whole spectrum of surgery, going from lymph node transplant to lymph vessel transplant to preventive LVA to therapeutic LVA to lymph node to vein anastomosis to debulking liposuction to radical excision. So I was fortunate that I was trained by some of the tallest giants in our field and my mentors. I'm forever indebted to my mentors. So I um, I perform all of these procedures, and I think it's safe to say that I'm fairly proficient in all of them. So the reason why, by the way, lymph node transplant was the only technique that I performed when I first started treating lymphedema. Since that was the only technique that I performed, I at a risk of being arrogant, I would say I was pretty good at it, and I was fortunate that my results were highly favorable. So I stopped doing lymph node transplant not because I had poor outcomes associated with the technique. Actually, quite the opposite. I had, compared to what's published, some of the best outcomes compared to what's published in the literature. The reason we moved away from lymph node transplant is the same reason that you no longer use iPhone 1. I became a board surgeon the year iPhone 1 came out. And since then, we have iPhone 2, 3, 4, 5, and now we're on iPhone 15. I don't think anyone would be thrilled to use iPhone 1 today. By the way, that was 2007. Take a guess when lymph node transplant was initially described.
Wow. I think that was,
1990.
yeah, I was gonna say no here, but somewhere else earlier than here.
1990
Yeah.
by Professor Dr Chen.
Uh-huh.
And some people said Dr. Becker, Corinne Becker, but at 1990, we're in 2023. So shouldn't we have something better?
Mm-hmm.
Yes, I think we should. And in my opinion, we do. So it's not to say that lymph node transplant is not a good technique. I think it was at one time, the only proven technique we had. And to me, it served its purpose. It was at one time state of the art. And in my opinion, as of today, well, I have to, out of my respect to my colleagues who hold different opinions, there are surgeons who still perform lymph node transplant. As I said, even in 2023, if you love iPhone 1, it will still work. I think you can still reliably make phone call. It is still an iPhone. But I think no one would say iPhone 1 is still state of the art anymore.
Okay, got you. What is you will explain to the audience a little bit about like, your LV bypasses, what exactly that means?
So the LV bypass, or some people call it lymphovenous bypass, or lymphovenous anastomosis, or lymphaticovenular anastomosis, whatever the name, they all involve connecting lymph channel to veins. The concept is pretty simple. So the lymphatic system is obstructed. The venous system, on the other hand, is free flowing. So you create connections between these two systems. You're connecting a congested system and partially obstructed system to a system that is working. So in a way, you can think of a congested freeway, and it's congested. There's an accident on the freeway, so everything is backed up, and now you're creating detours to decongest the traffic. So that's how LVA works. So LVA is definitely among the most nuanced procedure that, as a surgeon, that I think it's definitely among the most nuanced procedures that I have come to know. Excuse me. I see many surgeons either overestimating the technique or underestimating the technique. Surgeons are either taken aback or being intimidated by the super microsurgery aspect. Super microsurgery is fairly demanding, technically demanding, but in my opinion, any surgeon can, if he or she really wants to train to become a super microsurgeon, I think anyone can. So no reason to be intimidated. And there are surgeons who invested the effort, trained themselves in connecting tiny vessels together. But I think they underestimated the technique, the surgery, in that they assumed that the moment they learn how to do these tiny connections, the surgery would work. In order for the surgery to work, a lot more things need to be in place. That involves proper patient selection, proper incision planning. Given a lymph channel, where are you going to make the incision? At which spot, which segment along that lymph channel you're going to bypass? And in a given incision, let's say you have 3 lymph channels and only 1 vein. How are you going to bypass them? Are you going to do 1 connection, or are you going to make 3 connections? And if you're going to make 3 connections, how are you going to connect them? Are you going to do the intussusception technique or octopus technique? Or are you going to do 1 end-to-end connection, 2 end-to-side connection? So there are all kinds of considerations. And then how are you going to manage the patient after surgery? Are you going to do compression immediately, or are you going to wait for a little bit? And if you're going to compress, how firm are you going to be compressing? Are you going to be compressing with bandaging, or you're going to be compressing with garment? I mean, there's all these to talk about. And by now, we have performed over 1,000 cases. Yeah, easily. Over 1,000 cases of LVA. And I can tell you, this is a procedure that consistently humble us. And so many things need to be done right in order for the procedure to work. But when things are done right, this is an incredibly powerful technique. And time again, we were amazed at how incredibly effective this procedure is.
So you mentioned something about compression. I know it depends, right, of the patient and depends of the LV bypass you do. What do you usually do right after surgery? Do you go into like the compression bandages, or you go into the garment?
So, there are different opinions when it comes to this particular issue, but I will try to help both patients and my fellow surgeons alike. I'll stick to evidence-based practice, and I think many may not be aware of some of our studies which are published. So there is a dogma in classical microsurgery, which is no pressure at where the anastomosis is performed.
Yeah.
Okay, that's the classic dogma in microsurgery. So if you want to follow that dogma, that means no pressure
Yeah.
at your LVAs.
Uh-huh.
So I can tell you 15, 20 years ago, no one knew. No one knew. So can we compress the LVA? So that's why you probably have heard surgeons saying no pressure. After my LVA, no more compression. And you might have heard surgeons saying no compression for 3 weeks, and then okay to have to start mild compression
Uh-huh.
So come on, is compression helpful or not? If compression is helpful, then shouldn't we start as soon as possible? If the compression is not helpful, why would you ever want to start? So we have conducted a study precisely to address this issue, and we published, I think, 6, 7 years ago. If you search, you'll find it. The title of the study is it helpful or harmful to perform compression following LVA?
Okay.
And I will just tell you the result. The result is unequivocal. Compression is incredibly helpful. So there are favorable LVAs and there are unfavorable LVAs. Unfavorable LVAs are the ones with high venous pressure. So these are the LVAs that don't drain very well. And favorable LVAs are obviously the ones with high lymphatic pressure that overcome the venous pressure. So you have a nice washout. I can tell you that with compression, the LVAs that were demonstrating washouts drain even better. You pressurize the lymphatic system so they drain even better. And the unfavorable LVAs, when you compress them, when you leave them in their natural resting state, they demonstrated unfavorable backflow. But with compression, you can convert most of them into favorable LVAs with nice washout. So the finding was definitive that compression was helpful. And a secondary finding was that uh, the the stronger the compression, the better.
Okay.
So if you do 30-40, it'll be better than 10-20, 40-50, even better than 30-40, until you reach a critical pressure at which everything shuts off. You're just so compressing so strongly that everything shuts off. But most of us don't need to worry about that because that shut off pressure is so high, you're not going to reach. So the shut off pressure has been found to be about 80 to 100 millimeter
Wow.
mercury.
Wow.
So,
That's pretty high.
so before you get there, toes and fingers would turn blue and patients would be alarmed. So I don't think we need to worry about that.
Okay. So on your
So
practice, mainly the
compression
is
is helpful.
compression. Yeah. Okay. Perfect. Yes. That's very good to know. Um, I and then one last thing here before I let you go. I'm really dying to know because unfortunately at the last National Lymphedema Conference, I have to leave earlier due to my son had a competition that I couldn't miss. But I'm so wanted to know about Alzheimer's and Parkinson's disease. You want to tell us a little bit about that?
Okay, so um, all right, again, let's stick with what has been already discovered and so current evidence is suggesting that Parkinson's, Alzheimer's, and several other brain disorders are created as a result of brain's lymphatic dysfunction. So if you want to call them lymphedema of the brain, you wouldn't be too far from the truth. So those are what has been found by neuroscientists. Those were not our findings, and they are already well published. If you search on PubMed, you will find lots of discussion about the G lymphatics or the glymphatic system and the meningeal lymphatic system. So the question now is, can we treat them? Now, we certainly, as of today in 2023, I think it's fair to say that we have highly effective treatments available for extremity lymphedema, lymphedema of the arms and legs. Now, can these very same treatments work for brain's lymphedema? I think we can be cautiously optimistic, and there are certainly preliminary evidence that suggests that there is that possibility. And again, I think we have a responsibility to get to the bottom of it. And that's basically where we're at. We are rigorously pursuing and investigating this possibility. And so stay tuned. I
Okay,
think much more to come.
that's exciting. That's super exciting. And then how can people connect with you, Dr. Chen? How can they find you?
I think patients are already finding us. We're currently so that's one thing that we can do better. We are clinic to treatment time. So we see a patient in the clinic today. We decided that we're going to offer surgical treatment. We are getting to our patient in a delayed fashion. Although we've been getting better, at our worst, our clinic to surgery time was 1 year. So
Oh,
we would decide to operate on the patient today. We get to the surgery a year later. We're now down to about 5, 6 months. But this is definitely telling us that we need to do better. We need to increase our efficiency. We need to train more surgeons, and which we are currently doing. By the way, the very first our lymphatic super microsurgery fellowship has just started this year, and to my knowledge, it is the very first formal lymphatic super microsurgery training of its kind in the world.
that's a
So
congratulations.
we are training more surgeons like ourselves in order to help this immense patient population. There's too many patients and not enough of us. And as we were just saying, the reimbursement situation is quite problematic. The insurance company, what they're doing right now is not right. They are giving patients a hard time. They're frequently not covering lymphatic surgery. Actually, I was just told by our patient today that the insurance company, her insurance company, this particular patient had surgery done by us already. And her insurance company, even though they had agreed to cover her, they pay everything. They pay the facility fees. They pay the anesthesiologist. The only fees they left out was the surgeon's fee. And that meant my department didn't get paid. And this
Wow.
is fairly common. What the insurance companies are doing is they are penalizing the surgeons.
Wow.
So, so if you can imagine, if this goes on long enough, eventually surgical departments will say, we're not going to allow you to do free surgery.
Yeah.
And this is part of the reason why there's so few lymphedema surgeons.
That too. Yeah.
So, yeah.
Yeah. Well, and again, I will try to put like you're at the Cleveland Clinic, right, in Ohio. So I will try. I will put that on the description of the podcast or on the notes of the podcast, so they have a way to connect with the clinic.
So, yes, I'm at Cleveland Clinic. I'm not necessarily saying that all patients should come to us. I think we all should work on raising the awareness and helping our patients, educating our patients, and also encourage more surgeons to join us in helping lymphedema patients. And but even if we can't directly offer you surgery, just because of our limited capacity, I would encourage all patients to take advantage of our research, our knowledge, as we are freely sharing many of our published discoveries. And I certainly do a lot of lectures, and many of them make their ways to YouTube. So if you get on YouTube and search for my name and lymphedema, you will find many of my lectures. Actually, very few were actually meant for patients, but since they're there, might as well take advantage of them. And so yeah, that I think what I can share with all the patients is so lymphedema patients were once a neglected group. I think this was a patient demographic that was neglected by mainstream medical community, but not anymore. I can tell you that lymphedema is now the hottest topic in reconstructive surgery. Now, every plastic surgery candidate who, well, not every, but many, so many candidates who want to apply to Cleveland Clinic plastic surgery residency program or fellowship, they would tell us, I aspire to be a lymphatic super microsurgeon. So you're no longer neglected. Now you are at the center of our attention. And there are so many bright minds around the world, all focused on helping you. So we already have effective treatments, but rest assured that there's going to be something even better to come. Our predecessors have started lymphatic surgery 1.0, and we have evolved the 1.0 to 2.0 and 3.0. Rest assured that there's going to be 4.0. There's going to be something even better than what we're doing today.
That's amazing. Well, Dr. Chen, I can talk to you for hours. You have so much wealth of information. I will kind of like want to squeeze out of your brain, but I know you're busy and you have to go, but I really, really appreciate you doing this with me. And like I say, I will put some of that connection in the podcast notes so people can reach out and hopefully get into your resources. So thank you again for being with me today.
Thank you for the opportunity to share my thoughts. And yeah, I really enjoyed this. Thank you.
Thank you. Have a good evening.
Okay. Bye-bye.